Thanks for having me to the committee. Always happy to be among friends at the General Thoracic. I'm sorry for the jacket. I'll be in golf clothes later today, but I feel kind of naked on a podium without a jacket. So I'll talk a little bit about what we've done at Stanford in terms of setting up a program and some of our early experience actually screening patients. A little bit disappointing in terms of the number of patients. Betty didn't say anything about how many patients. How many patients did you guys screen in your first year? Yeah, so we had 49. So if you think this is going to feed your thoracic surgical volume, it is not, okay? But
Yet. Because it's not reimbursed.
We'll see. So anyway, I'll give a little bit of the early experience. So obviously here's the paper. Betty picked some, I picked some of the things that I think are the most important to remember, which you'll be called upon to discuss at your interdisciplinary meetings, et cetera. 20% reduction in lung cancer specific mortality. 50% of the tumors identified were in stage 1 as opposed to our usual horrible distribution of stages. 25% of patients were screened positive. 4% of screen positives had a surgical procedure. So look at those two numbers. 25% were screen positive and 4% had a surgical procedure. So something like 1 to 2% of the overall screen patients are going to have a surgical procedure. And that's if you're doing it right and carefully and not overdoing surgery. And there has been a 23, this is all in the NLST, a 23% false positive rate among surgical procedures, which seems reasonable to me. If you look at papers of VATS wedge resections for pulmonary nodules over the years, sometimes they're as high as 50, 60%, which is probably inappropriate. 23% I think is pretty reasonable. So I had actually tried a long time ago, based on the New York hospital experience, to try to get a screening program going at Stanford. And Stanford's a very scientific place, and without randomized data, it was not going to happen. I mean, the radiologist, like you said, our head thoracic radiologist just was not going to have it. And the data from Henschke, I think is her name, just was not good enough. So there were whisper numbers sort of after the NLST closed, but before it was published. And at that point, I tried to reinitiate the conversation, and again, I sort of got nixed. So then, finally, when the paper was published, people were all in, and we started to really have meetings to try to put it together. So I think at this point, you won't have any problem getting buy-in from people. You'll just have to work out some of the details. There was still concern about a number of things, one of which being who's going to pay, and the other ones being everything I've listed here. On the left, sort of the more administrative things, in whose purview is this going to be? Where is it going to be done? Because we thought if there were going to be a ton of patients inflowing, it would be intensive use of the CT scanners. What are the charges going to be, versus insurance, marketing, and then the more interesting, probably medical questions on the right side there. Which entry criteria were we going to use? Again, this was all before we had a whole list of criteria being published when we were first talking about this. How is follow-up going to be done? And then how are we going to include smoking cessation, which Betty explained is a very important thing. And a lot of that comes down to having some funding. So we started having these meetings between chest radiology, myself, a representative from pulmonary, and a hospital representative to go through these things. So I'll go through these questions basically one at a time and tell you how we sorted them out. So in terms of funding, we actually found that it took less than you might think. It didn't take a lot of extra dollars because we had a lot of things already basically on site that just had to be tapped into. The things you really need are space, FTEs, or an FTE in our case, and marketing in terms of funding. Space was not a problem. We had the perfect site for it, which I'll describe a little bit later. Marketing was not a problem. We have a pretty vigorous marketing program through the Cancer Center at Stanford, and they already had the funding and were happy to use that funding to go ahead and market this. So it really came down to the FTEs. I saw Nasser Al-Turki give a talk about this, and he said that you need 3 or 4 FTEs. That may be true if you're doing the kind of program, they've got a mature program in New York Hospital, which has been growing for many years, and maybe that's what they have at this point. But we found we kind of wanted to get 2, but we ended up getting 1 with a guarantee to get a second if we did more than 150 scans a year. So we started with one FTE, and what that person was really the, no. What that person was is really the intake person. So that's a nurse, an RN, who we basically trained to be knowledgeable about all of this, and both took the initial calls, screened them to make sure they were candidates, does the follow-up, contacts them with the results, really does everything. I think it would be nice, and when we get a second person, we will have sort of a database follow-up person who will be more in touch with what happens down the road on each patient. Right now, this person is keeping a database, but it's probably not perfect. You really need smoking cessation. We already had that, again, in place, and it was just a question of incorporating it into the program. You know, the argument that you have to make to the hospital, of course, is that the downstream economic benefits of this are going to justify any cost that they put into it. So like I said, we got one FTE, marketing, and a promise for a second FTE if needed. So in whose purview is it going to be? I've heard many people say it has to be within surgery. I don't really think it makes sense to be within surgery, and we made a decision early on that, you know, the downstream benefits are so removed from surgery, you know, they're basically public health benefits, that for it to be a primary effort of us to organize, I decided that we wouldn't do, and we let the radiologists have it really within their purview. So it is within radiology. I am a co-director, but honestly, the head of radiology probably does most of the work. I think the reasons for surgery to be involved are basically that we're really good at quality. I think surgeons are the best people in terms of quality, making sure it's running smoothly, making sure the appropriate things are being done. Obviously, there can be errors on either side with these patients. They can be overtreated, which would be terrible, and they can be undertreated, which would be terrible. And it has to be clear that there's a protocol that's being adhered to and that is established and agreed to by everyone. And I think that's the role of the surgeons, because the radiologists, you know, obviously are very good at radiology, but don't really understand the clinical side of lung cancer. And then in terms of research access, there are a lot of potential benefits in terms of ongoing research that can be done out of this, and I think you want to be closely involved so that you know, people in your group can tap into the research possibilities. So the site, as I said, was pretty easy for us. We had an underutilized CT scanner at a site that's about 4 miles from the main hospital in an outpatient center that's mainly orthopedics, neurosurgery, and some medical subspecialties, including interventional pulmonary. And there's an MRI there that's used a lot, but there was a CT that wasn't being used a lot. There was also a lot of space there. And in Palo Alto, like a lot of places where you guys are based, it's not easy to get space. So we sat our RN there, right next to the scanner, and it is removed from the physician, so we don't have the kind of situation you have in Duke. The parking is better out there, and so it basically worked out from a lot of points of view. Charges was sort of a sticky issue. And remember, this was arranged initially before the anticipated funding decision by the feds. And as you know, some places have done this for free because they've convinced their hospitals that that the downstream benefits will make that worth the hospital's while. So that did not fly at Stanford. The hospital felt that a lot of the insurers would pay for this, or at least some of them would pay for it. And so therefore, they wanted to be able to charge full price for those that are insured for it. But then they also wanted to be able to provide a reasonable price for patients who aren't insured. So the way we set that up is basically on all the paperwork, and one of the first things that our nurse says to patients who call to set up a screen is that there are some insurance plans that do not cover CT lung cancer screening. Therefore, if you receive a notice of non-coverage, basically we're going to give you this discounted price. It has to be called a discounted price, otherwise the insurers won't pay the full price. So the discounted price is $495, it's $425 to the hospital, and $75 to the chest radiologist, which is a significantly discounted price for a chest radiologist. So they end up paying about $500 if insurance doesn't cover. Marketing, as I said, wasn't an issue. They quickly put together some materials, and it went out to all of the pulmonologists, primary care doctors of any type within a 300-mile radius of Stanford. So this is the front sheet that went out, and the guy in the pink sweater also shows up in the stuff that went to patients. That was all given to patients. There was obviously a web presence that we developed and linking between all the lung cancer sites within Stanford on the web. So we decided not to do direct-to-patient mailings. Did you do direct-to-patient mailing? Discussing it now. So we did not do direct-to-patient mailings. One thing I'll discuss later, I'll leave it for later. So eligibility, now we're getting to sort of the crux of it, right? We, at some point, at least in the era we were in, before there were a lot of published guidelines, there was some conflict between myself, the other surgeons in our group, and the radiologists about what criteria there should be, because we felt we could pick out some high-risk groups that were not used in the NLST. We ended up electing sort of a middle ground, and ultimately what we've evolved to now is NCCN plus, I guess you could call it. So here are all the various guidelines or recommendations. I guess the thing that Doug did with Gaetano Rocco is sort of a paper. I don't know, what do you call that? A consensus statement. So there are a lot of different things out there. We ended up basically taking NCCN, which takes the age down to 50 years, as long as you have a 15-pack years smoking history and one additional risk factor. And then the funding decision, the USPTF actually extended the NLST age up to 79 from 75. So now you're basically to 50 to 80. And that's what we've used. And then in addition to that, we've added a couple things of local interest. We have a huge population of Asian non-smokers who get lung cancer in the Palo Alto area. It is incredible. It's more than a third of our lung cancer is in that population now. And a lot of those patients are very well educated and have a family member who has lung cancer, and they want to get screened. And there is some data that it's familial. So we decided that we would screen those patients as well. So that's one of the plus. And then, as I said, we took it up to age 80 as the funding decision did, or the funding recommendation. All the patients need a referring doctor. They can't just walk in off the street and have it. They have to tell us who their doctor is, and the doctor has to contact us. But they don't have to see us. They don't have to see one of us before or after. If they have a positive screen, then they get given the contact information and offered referrals by a telephone call to either our pulmonary nodule clinic or one of the thoracic surgeons. All these things obviously were sort of negotiated in a group with our multidisciplinary clinic. And then how do you follow them up, which is probably the most important area. And we initially had our own follow-up, basically arrows that we designed, but now we've pretty much gone with the NCCN guideline. Obviously there are occasional patients, or there will be, who will not accept what the guidelines tell you, and they require individual counseling. Basically, they're going to accept to see either a surgeon or a pulmonologist, and then it's going to have to be discussed. These are the NCCN guidelines. I mean, there's a separate guideline. If you haven't looked at them, you should when you get a screening program going for, and appropriately so, for solid nodules and ground glass nodules. And basically, it's all based on size, where you head, and the sizes are a little bit bigger if you're talking about ground glass nodules. Reporting is an important issue. In fact, the American College of Radiology right now has a task force that is trying to set up, there's something called BIRADS, I understand, for mammography reporting, where there's very standardized ways of reporting mammography results. And they're trying to set up the same thing right now for lung screening results, but there isn't such a standard within the radiology community right now. So what we've done is basically sat down together again in our multidisciplinary group and wrote out and very carefully, vetted among all the stakeholders what the report is going to say. Again, this is important probably more for us even than for you because they're not seeing one of us initially, immediately to talk to us about it. So what the report says is very important. It goes to both the patient and the referring doctor. They're offered a referral, as I said, to the nodule clinic or a thoracic surgeon if they have a positive. And then the patient's also called about, obviously, a positive and about when their repeat study is scheduled for. If it's a positive, it might be a 3-month study. If it's a negative, it'll be the next year. Smoking cessation was an issue. We wanted another FTE for smoking cessation, but we already had smoking cessation in the hospital. So because we were off-site, it made it a little difficult to kind of bring those things together, and the hospital didn't want to pay for an additional person. So what we did was basically gave them an appointment to go see the smoking cessation person at a different time point in the hospital. And of course, we gave them all the usual phone numbers, 1-800, no buts, and that sort of thing. But it's probably not as vigorous as it should be. A couple of other organizational details. The Multidisciplinary Tumor Board has been the site for almost all of this other than kind of the business stuff. That's where the initial setup was approved. The diagnostic protocols were approved when we decided to go to NCCN. That was agreed upon amongst everyone, including radiation, medical oncology, pulmonary, and ourselves. We have had a couple of controversial sort of findings that we've discussed in that group that the radiologists bring. And then every 6 months we do a quality review where basically the numbers of cases, what's happened to the cases, how many are positive, et cetera, is gone over in that group. Then for research, we have a monthly thoracic oncology clinical research meeting where we go through all of our clinical trials, et cetera, and that's been the venue for trying to use CT screening as a research avenue. Somebody at Stanford just basically invented a way to very sensitively diagnose lung cancer using circulating DNA, something that's going to be published in Nature. It's like amazing work. And so we're obviously using the nodule clinic to work that out in a more clinically useful way. So the volume has been modest at best. I don't expect an avalanche, and I'm not even sure there's going to be an avalanche after payment, but I don't know. We did 48 scans in our first year. We're now in our next 6 months. There were 9 positive scans, and none of them have come to a procedure or a surgery or have been established to be a cancer. So this is not going to lead to a huge volume of thoracic surgery. Now, some lessons that we've learned. Most insurers are paying in California. Our Blues are paying, and many of our under 65-year-old patients are Blue Shield of California. Again, at 1% to 2% cancer diagnosis is not something to base your clinical growth volumes upon. This is a public health thing that we're doing. We haven't had any nodules yet from this, but we see a ton of small nodules, and I expect if you have a lot of positive screens, what you're going to end up with small nodules that need a VAT segmentectomy. I think if you don't know how to do VAT segmentectomies, that's something to focus education on among the residents, et cetera, because that's going to become a very more commonly used operation. Some of these things are going to be so small, I think, or sort of centrally placed in a segment that a wedge is not going to be enough, even if it's a pure ground glass opacity. So VAT segment is becoming an operation that I use all the time. Again, not because of our screening program, but just because we have a lot of ground glass nodules. Questions that are going to have to be answered in the coming years, I think, are what to do after 3 years. Remember, the NLST only screened patients for 3 years, boom, and then that's it. So does that mean everyone should be screened for the rest of their life who meets criteria? Seems like a lot. They're going to get, it's about 1/8 the dose of a regular CT, no, about 1/5 the dose of a regular CT scan, yeah. So it's still a lot of radiation if you get a CT scan every year and you're 55 and you're going to get it until the end of your life. So that's something to be sorted out. The NCCN gives only a 2A recommendation for doing it for the duration of somebody's life, but a level 1 recommendation for 3 years. And what will the indications end up being? What how strong will the data have to be to extend it to, say, patients who have had an operation for non-small cell lung cancer and are now 5 years out from their operation? How do you follow them? Seems like a low-dose CT would be perfect for that group. I think the AATS guideline recommends that. That's not something we've adopted, but it's something, as I wrote this talk, I reminded myself I want to talk to our radiologist about it. So the other thing I think that's really important that we have just begun to do, and I didn't think of it myself, RAS had an abstract at the STS this year, which basically said they went to their privacy people and they said, can we just screen our medical record for people who meet criteria and then call them? And so I went home and did that right away, and so we're in the midst of screening our medical record, and we've got, right off the bat, 400 people who are going to get contacted to be screened. So that's something that I think could really increase the number of people who get screened. CMS coverage is expected, I guess it's not guaranteed, sometime around January of 2015. And I think there will be a substantial increase in volume, but again, it still has to be something that primary care doctors and patients hear about and therefore set up to do. We're going to be going back soon for a second FTE, really to be more of a database and follow-up person. So this is something that's very doable, even on a relative shoestring. If you're in I think if you're in a major center where you already have a lot of this stuff sort of around, it's natural to me for it to be run through radiology. I like the way it sounds like you guys are doing it, but space-wise, I don't think that would have worked for us. But certainly surgeons need to be directly involved, and we were directly involved all the way through and in ongoing sort of evaluation of it. It's critical to get everybody on board and kind of approving the guidelines you're using and the criteria for when they get a repeat scan, et cetera, right up front. So everybody, all the stakeholders are happy. Our volume has been lower than expected, but that could change quickly, and we'll see. I think that looking through the medical record and selecting patients and calling them is going to be one way that'll increase it, and obviously the payment decision. You definitely need to set up regular quality reviews to make sure that things are happening as they were set up, and we've been doing that. And I think one thing we didn't do so well, which would be important to do, is to really think through the research options from day one, make sure the bloods are being drawn that you want to have drawn, make sure the database is really set up well. That would be a lesson learned for me if we were to do it again. And obviously this is something that's really important to do from a public health perspective, but I don't think it's going to markedly increase your thoracic surgery practice. Thank you.